want to share with you two studies that I did within the last year that I think are very interesting and put a new perspective on privacy issues. And those two issues are, number one, do young people care about health privacy? And I think that's a very important issue. And number two, is compelled disclosure of health information a major privacy issue? And we'll talk about both these. So the first one is, do young people care about health privacy? And I think that's one of the questions that I've received many times over the last 5 to 10 years. People have said, why are you so concerned about health privacy? These young people really don't care about it anymore. Privacy's dead, and you need to pick another line of work. And so as part intellectual interest and part career preservation, I decided to actually test that hypothesis, that young people don't care about privacy. And we divided the group by generations, millennials, Generation X, baby boomers. We also sought to get older generations, but the numbers were too low to actually be reportable, right? So the silent generation or the greatest generation, we only had a handful of people who responded to the online surveys. So if you're not familiar with it, who makes up these generations, and I'm not sure you can read that, but this is a Time cover that says, the me generation, millennials are lazy, entitled narcissists who still live with their parents. Why they'll save us all. And about Generation X, Time said, you called us slackers, you dismissed us as Generation X, well, move over, we're not what you thought. And then we come to baby boomers, and I don't need a Time cover for that, because I am the self-appointed representative of this generation of people, and I can describe this generation. We are low-key, easygoing, mild-mannered, and especially laid back, and my evidence is this. And this was a colloquy at Woodstock in 1969 demonstrating how laid back our generation is.
That was you, Mark.
Well, there was somebody, but I didn't want to point that out. Okay, so we did an MTurk survey of 1,319 people, and here are the demographics, as you can see. Mean years, 36, and here's the breakdown by generation. That's why we only had 9, so we didn't use that statistically. About half men and half women. There's the ethnic breakdown. The education was at a level that's slightly above the population and income as well. And they were primarily with health insurance. Only 12% did not have health insurance. Slightly more liberal politically, and certainly a slightly on the risk-taker side. So here are some of the data that we got, and I think it's fascinating. I should say, by the way, that this article is pending for, in a journal, and so we should have it published pretty soon. So we asked them whether they use social media sites, and interestingly, all 3 generations were over 91%, which is high, but of course this is a self-selecting group of people who are taking an online survey, so you would expect that. Then we asked them, have you ever regretted sharing information on social media? And the laid-back generation, only 25%, but the younger generations, almost 50%. And we asked follow-up questions, well, what kind of things, but we don't have time to go through that. And do you use health and fitness devices? And you see it declines by age group, which I think you might suspect. Now here are the kind of bottom line results of the survey. We found that there were the following predictors of level of concern about the privacy of health information. And this is responding to a question, how concerned are you? Not at all, mildly, and so forth. And those with higher education are significantly more concerned about the privacy of their health information than those with lower education levels. Older generations were significantly more concerned than younger generations, and minority racial and ethnic groups are significantly more concerned about their privacy than non-Hispanic whites. Now let's look beyond those bottom line figures to get some other data. By generation, these are the breakdowns. When we originally did this, the millennials were altogether 18 to 35, and it was in the high 60s, which in light of the other generations was pretty much the same. But then one of our researchers said, let's break the millennials into older millennials, 29 to 35, and younger millennials, 18 to 28, and now it just pops out at you. So there's a really substantial difference between the 18 to 28-year-olds and everybody else. And apparently, something happens at age 29. And at age 29, or thereabouts, people have families, they've got homes, they've got mortgages, they have jobs, and so on. And they're concerned about health insurance, who's going to get access to it, and so forth. At least that's a theory, but I've never seen this broken down quite that way. Then we ask them, has your level of concern increased over the past 10 years? Now, for the youngest millennials, they were only 8 at the time, but still we wanted to see whether it's increasing or decreasing, and you see for all of the generation groups, they're more concerned now about health privacy than they were before. The two older groups, about the same. Still, even for the millennials, more than half were concerned about that. Well, what were they concerned about? Interestingly, how they tracked pretty much the same. Number one was identity theft. That was the red, of course, is the baby boomers, who were concerned about identity theft and also financial loss. For the millennials, it was embarrassment, but pretty much the same track. This, I think, is another interesting slide. So we wanted to know whether there was a discrepancy between what people thought about the various generations and what the individuals who were in that group thought about it, okay? So let me work backwards. So the perception of the willingness of people in this group to share information for baby boomers was pretty consistent, right? On this 10-point scale, 4.7 versus 4.3. So in other words, people were actually less willing than people thought they were to give out information. That increases when you go to the Generation X, where it's 6.1 versus 4.8. And now here is the millennial group, where it was perceived that 7.7 on a 10-point scale would be willing to give out information, but they themselves were much lower. So perhaps we are overestimating the lack of interest that young people have in privacy. So let me share my conclusions on this first of the two studies for you. First, I think you could argue that the survey overestimated concerns about privacy because they were more educated than the general population. On the other hand, this was a pretty self-selecting group. People who are afraid of privacy violations aren't going to take our survey. And so I think it may have actually understated the degree to which people in the population are concerned about privacy in general. Younger adults, as we discussed, are somewhat less concerned than older adults about health privacy, but all of the age groups are concerned about maintaining the privacy of their health information. And then finally, this is my theory, that age-based differences are not generational differences, but life cycle differences. In other words, that these 27 and 28-year-olds, when they become 37 or 47 or 57, are going to have views much more like the older generations now when they move through their life cycle. I can't prove that. Those of you who are younger and want to follow this up 25 years from now, I'd be very interested in what you find. So 25 years from now, I will be at the privacy experts retirement home, and you can look me up, but we're probably not going to have a listed address. Okay. So I want to acknowledge my colleagues from Baylor College of Medicine in Houston who were in on the survey work with me. So the second question, and then I can, at the end, I'll take questions.
I just want to ask one question.
Okay, sure.
I'm wondering about the 29-year-olds, and when they turned 29, what year was that approximately, do you think? So I'm wondering if there was also something happening in the greater world around us at the same time that these folks turned 29 that affects
well,
the life cycle.
the survey was done last year.
Okay.
So, and it was before November. Does that answer your question?
That's what I was wondering.
Okay, you got it.
Thanks.
Okay. Skip.
I think you probably answered this question, but I didn't hear it. Going back about 3 slides, your perceived slide, is that perceived
I'm going the wrong way.
in that age category?
No, we asked them their perceived. We asked everybody about every category.
Got it.
Okay. So the second issue that we studied or that I studied in the past year, was about the issue of compelled disclosure of information. Many times in the privacy world, we study security issues, how we can protect against the bad actors, the people who are hacking information, are misusing information, or doing all sorts of illegal things. Of course, I'm concerned about that, but I'm also concerned about entities and individuals gaining lawful access to private information, and whether we consider that seriously as we must. So I was concerned about this issue, and in 2007, I published an article in the American Journal of Bioethics with my then colleague Megan Talbot, in which we tried to quantify the number of compelled authorizations for disclosure of health records. In other words, if you apply for a job, and certainly if it's a large employer or it's in an industry where there are serious safety concerns, you will be asked to sign a HIPAA-compliant authorization, and they will get access to your medical records, and they may send you for an additional medical examination. If you are applying for life insurance, depending on the policy amount, you're going to have to disclose your health records. If you're applying for a Social Security disability, you have to disclose your health records. If you've got workers' comp, and adding all these up, I was wondering, what are we talking about in numbers? Are we talking about 10,000, a million, 10 million? And part of the policy that we decide on is related to how many we're talking about. So we did this study in 2007 and published it in this journal, and the reaction was, well, there was no reaction. And in fact, in the last 10 years, there's never been anybody who studied this issue, who've said you're right, who've said you're wrong, who've said this is really important, who've said this is not important at all. So I thought it was about time that we do a follow-up. And the reason for the follow-up was that things have been happening in the last 10 years with regard to health privacy. Of course, we've got the enactment of GINA in 2008, the HITECH Act in 2009, and I mean, the implications for privacy, of course, are, for example, the HITECH Act marked a shift to electronic health records, which has all the privacy implications that you're aware of, the Affordable Care Act, and also this consolidation in healthcare that was driven, I think, in large part by the changes in the healthcare system as a result of the ACA. So in other words, if you went to your neighborhood psychiatrist for depression or whatever, you may have selected a doctor who was practicing on her own or on his own, and you thought that your records may have been, protected there. Well, the local hospital is buying up all these individual practices, including psychiatric practices, and now that information is in a large database that's accessible to anyone who has lawful reason. And of course, as this group knows, under the HIPAA privacy rule, the only exception is for psychotherapy notes, but not for diagnoses. So Megan Talbot is now working for the California Blue Shield. I haven't seen her in a number of years, but because she was a co-author, I thought I have to ask her if she wants to redo our study, and she said, of course. So we did another study, and we tried to update our data, and in the current issue of the Journal of Law, Medicine, and Ethics is the 2017 version of our study, updated estimates. And I want to go through both sets of estimates together with you, and I think it's really very interesting. I am very sorry for this slide, but I don't know how to get all this information in one place. So let me try to explain it to you. On the left-hand side are the disclosures that we're talking about, starting employment entrance exams to personal injury lawsuits. And then here are the 2007 estimates, and we wanted to have next to it so you could compare. The 2017 estimates are new estimates on it. Now, each one of these estimates is a very complicated set of assumptions and so forth. So how do we get the number of compelled disclosures in employment entrance exams? So we found out, and I'll use the 2017 numbers, that in the most recent year for statistics, 2015, that we used, there were, according to the BLS, 60 million people hired. And the reason it's so high is because they count part-time employment, and also it counts people twice. Because if you go to work for company X and you don't want to work at McDonald's and you quit and you go to work at Burger King, then you're twice in the same year, even though it's only a part-time job. Okay, so there's 60 million of these, and we found out from other surveys that we didn't do that about 40% of manufacturers and service industry jobs, all sectors, about 40% require some type of pre-placement medical examination, 40% of employers. It actually represents maybe 60% of individuals, because who does these examinations? It's only the large employers that can afford it, and it would be the industrial kind of jobs where there are many of the hazards. At any rate, so 40%, we didn't use the larger number, 60%, we did the 40% number, and we estimated from discussions with occupational physicians that of those who are doing pre-placement fitness for duty exams, about half would just examine you and and the other half, they would examine you and also require you to sign an authorization for your records. So we start out with these 24 million, and then we have the discount factor to 12 million. So it went from 10 million in 2007 up to 12 million. For individual health insurance applications, it's interesting here, before 2010, we had it estimated 550,000. That is zero, right? Because under the Affordable Care Act, you can't discriminate against individuals in individual health insurance on the basis of their pre-existing conditions, et cetera, et cetera. So that number is currently zero, but there may be a possibility that it's going to be higher than zero. Individual life insurance applications, there were about 13.6 million in 2007. The people are not buying life insurance the way they did before. We're down to about 10 million and resulting in 5 million examinations. Long-term care insurance, if you're not familiar with it, the industry is hanging on by a thread. It barely exists anymore. 10 years ago, there were 100 long-term care companies. There are now 12 in the market, and the reason for that is insurance companies can't make any money on the product. The lapse rate is very low. In other words, people who start with policies continue paying, and insurance companies often make money when people pay for 5 years and then drop the policy. They haven't paid out on it. At any rate, so individual long-term care insurance policies went from 200,000 down to 65,000. Individual disability insurance went up from 400, and here the 50% reduction, and it goes to 600 and 300. Disability insurance claims, this would be from both individual and group, 1.5 to about 2.1. We also studied auto insurance claims, 1.3 up slightly to 1.4. And here, in these areas, we only used a 20% reduction because it's a requirement. For example, if you are filing an SSDI application, Social Security Disability, you have to, as part of your application package, you have to submit your medical information. So at any rate, this went up slightly. Auto insurance from 1.3 to 1.4. SSDI went up from 1.7 to 1.9. Workers' comp, interestingly, we had about 1.5, and that has been halved. And there are conflicting reasons given in the literature about why there's fewer workers' comp claims. One is the decline in the construction industry and in heavy manufacturing, where traditionally claims have been found, but various other reasons. Veterans' disability claims, 632 to 800, and personal injury lawsuits from about 300,000 that we estimated to 185,000. None of these stayed the same. Some went up, some went down, some went to zero, etc. And yet the bottom line is, in 2007, there were 25 million, and in 2017, there were 25 million. The actual number that we got is less important than the sort of the overall picture, and that is how many of these compelled disclosures there are. These are entities that have a lawful reason for wanting this information. You claim you were injured in an auto accident. What's the doctor's report say? They're not just going to send you a check on your say-so, right? You claim that you're permanently and totally disabled. Well, what do the doctor's reports say? So they have a legitimate reason to know this information, but how much information do they get? That is the privacy issue that I'm concerned about. For some of these categories, the disclosures are of unlimited scope. And that's certainly true in the very first one for employment entrance examinations. So under the ADA, which is going to be regulating this, Section 102D3 of the ADA provides that after a conditional offer of employment, an employer is permitted to require as a condition of work that you submit to a medical examination of unlimited scope. The only limitation is after 2008, it can't include genetic information. So your potential employer can get everything. Even if there are limits in the authorization where it's indicated, give me information about Joe Smith's broken leg, the holder of the records, whether it's electronic or in paper form, it's too complicated, it's too expensive to start picking out what they're going to send. It's common, they send everything. And it's been proposed for over 10 years that our health record system adopt segmentation so that when you file a claim for your broken leg that you sustained on the job, the workers' comp carrier would have access to only your broken leg. But that has never been implemented. And even if it were implemented, and I've strongly recommended that, it's much more complicated. Because here's an example of the problems with segmented disclosures. So you got a man who applies to be a bank security guard involved carrying a gun. And the bank wants to check his medical records, and they find out that the man, or they don't find out, has sequestered his mental health and substance abuse history. So what we recommended at the National Committee on Vital Health Statistics was that there would be certain preordained categories that everybody knew what they were. And if you wanted to sequester your genetic information or your reproductive health information or your substance abuse information or something else that's sensitive, you could do that. Okay? Now the question is, should we allow an applicant for a armed security guard at a bank to sequester their mental health and substance abuse history? I think many people would say no. Because they carry guns, it's important. Well, what about for a school bus driver? Well, what about for a school crossing guard? What about, okay, so you very, very quickly get into different situations where people might differ on whether they think it's relevant and they should have access to that information. Finally, I want to talk a little bit about insurance and access to information by insurance companies. So at least under the Affordable Care Act, we are saying now the use of genetic information, or indeed any information, in health insurance is unacceptable, right? Because it's going to violate the Affordable Care Act. By default, we have basically said, because it's legal virtually everywhere, for life insurance companies to require that you submit all your information. They can use genetic information if they want as well. So my example would be, well, what about in between? And I want to take the case of long-term care because I mentioned it earlier. As some of you heard before, 23andMe was just approved by the FDA to return information bearing on the genetic risk of Alzheimer's disease. And the long-term care insurance industry, what should they do when they suspect that lots of people out there who are applying for long-term care insurance now already have a predisposition to Alzheimer's disease, which is going to jack up the cost of care for individuals in long-term care facilities, let's say. Should they be permitted to do that? If you don't let them do that, the whole industry may go out of business. On the other hand, if you do permit them to do that, now you're countenancing sort of blatant discrimination based on potential risk in the future. Well, it's not even that simple, because what's the effect going to be if we don't allow individuals to keep that information to themselves? They're not going to be able to purchase long-term care insurance. Who's going to cover them? Well, it's going to be Medicaid, right? Because they won't have the money for their own coverage. So it's now either the taxpayers or it's the premium payers for long-term care insurance. So as a matter of public policy, do we want to encourage, subsidize through our policies private long-term care facilities? Are people going to get better care? Is it going to be better for the economy? Is it going to be this, that, or the other thing? So every one of these issues, all those things on the left side, you can't solve them by enacting a law that's supposed to protect privacy. Privacy that's attached to consequences that sometimes we would call discrimination is very much involved, and it raises issues of how we want to allocate risks, how we want to share risks, etc. So the conclusions from the second part of my talk, the 2017 estimates are scary, to me at least, that somehow they're exactly like the 2007. Each disclosure and use of health records involves complicated and contentious issues of public policy that are not easily resolved, and compelled disclosures are an overlooked area of privacy research and advocacy. You probably have just heard about the only 2 papers that have been written in this field. And why is that? Because it's not important? I don't know. So with that, I will open the floor for your questions. Sir.
So with the discount rates in your data, did you make any effort to determine those like more empirically? And do you think if you like went back and did that, do you think that could potentially have a significant effect on the data, or you think it kind of washes out, I guess?
Well, in the last version of the article, there is a statement toward the end where, that is a 2017 version, these are more guesstimates than estimates. And the purpose is not so that we can say, we know how many of this. It's to get sort of an educated guess as to the magnitude of the problem in these various categories. And we used the best data that we could find. And I got to tell you, it was really hard finding data. And we had to interpolate. And we explained in the paper, if you're interested, how we came up with what figures and that sort of thing. And I called lots of experts, like the insurance industry and the, the human resources people and the workers' comp people to try to get as accurate figures as we could. And it's not possible. We actually can't get those numbers. And but I do think overall that it gives us somewhat of a picture, and it may help to a degree in policy. I believe, in evidence-based ethics, and to the extent we can get some evidence, that would be very helpful. So.
Crossing over, did you hear this talk before this one?
In this room?
Yes.
Yes.
Okay, I wasn't here, but I know of her work and I've talked to her. I think it's been interesting talking about the compelled, we talk about compelled exposure, disclosure, is whether or not paying, making people pay more for their insurance if they don't disclose this data that's not protected by HIPAA is compelled disclosure or not. And I would guess that would be used exactly the same way that some of this is being used, because it's not protected and it's sold to other entities like insurance companies and the rest.
Yeah, so
You've got one
for-
more category of compelled exposure.
Well, I've been writing on the wellness program issues for the last 20 years, and there was a panel discussion for those of you who weren't here in the earlier session on wellness programs and who has access to them and all those sorts of things. And I think the point really needs to be emphasized that this is a commercial product that's sold to gullible employers under the following situation. They say, we've got a product that's going to improve the health of your employees and save you money. It's a win-win situation, and many employers say, sign me up. And what happens at that point? So let me tell you about the program at our university, which is similar to that. I mean, universities are not immune from doing stupid things. And so if I signed up for this, our wellness program, I would have some unknown coach from out of state call me once a week to see what I'm eating and whatever is on their agenda. If I don't do that, I'm paying an extra X number of dollars a month. I can afford to do that. I view that as a privacy tax, right? The hourly employees who work in the hospital cafeteria, they can't pay that privacy tax. So they have to give up their privacy. And in many cases, you know, I'm sure you're all familiar with the data, who has the unhealthiest lifestyle, right? They're often low-paid people who live in food deserts and so on and so forth, and they're the highest rates of smokers and so on. These are the people who are going to be paying personally for these programs. And I am very much in favor of smoking cessation programs that are run through physicians, not forced on people by their employers. And the same thing is true of all sorts of things. I don't think somebody from some contractor is the right person to be, you know, monitoring your cholesterol level or your compliance with your diabetes medications. I just think it's a terrible idea. And to be even broader about it, I think that employers ought to stick to what their business is. And the more they're out of being the ICE enforcement agency and the drug abuse prevention agency and the obesity prevention agency, the better off they are and the better off everybody else is. And I think employers would actually like that, but they've been foisted with many responsibilities that are sort of alien to their businesses.
Plus, I'm sure they're pocketing a lot of that money that gets paid by those employees.
Well, I mean, depending how you structure it. I mean,
Right, but I bet they are.
some employers are doing it just to sort of reduce their costs. Others because maybe naively they believe it's going to work and they're concerned about the health of their workers. And if they were concerned about the health of their workers, there are lots of other things they can do besides this. Skip, did you have a question?
Well, I wanted to offer some thoughts about the differences among the generations.
Sure.
I haven't read your stuff. I'm sorry about that. And you may have already drilled down deeper. But in your writing, do you talk about what the factors are that cause the different generations, if there is a significant difference, to be different?
No, I think that may be an interesting follow-up.
Okay,
This
well,
was the sort of the first cut at it, and I know some of my colleagues from Houston have already written another paper about a more, narrow area, and I think there are lots of ways to follow up.
Let me suggest one possible way of looking at it is possibly a risk-benefit or perceived risk-benefit analysis. Older people, having lived longer, have had more life experiences which wise them up to the importance of health privacy. Maybe applying for a job, seeking a promotion, trying to get health insurance, things of that nature. Younger people have never applied for those things, so they haven't thought about it. So the importance of the activity is one factor. Another one is the assessment of the risk. I could be hacked. Some people think that's a very imminent risk. Other people think it's a very distant risk. But on the other side of the ledger, it's what do I get out of sharing that information? Young people, with their social media and other things that they do, are accustomed to, one could even say maybe addicted to, a lot of good things on the web. And even you and I, we buy something on Amazon, we'd like Amazon to know what we're interested in so Amazon can suggest something that we might also want to buy. If we value that activity or that information, we'll take a higher degree or accept a higher degree of risk in getting it. So you've got perception of the risk, willingness to take the risk because of the possible benefit, and then what your stage of life is. I'm not sure that you put that all together, it makes any difference in your analysis, but it takes it down another level.
I think the question of why is a very important one, and we asked some why questions, but I think it may be the kind of thing that lends itself to a more semi-structured interview, an hour long with each person. It's hard to do that so much in an online survey. We wanted to answer the sort of the basic question: do younger generations really care at all about privacy, especially health privacy? And I'm confident that the answer is yes. Now, going further, why and how much more than others and what causes change? Well, I'm less confident in that because there are all sorts of selection bias and so forth that are built into this kind of research. But as a result, I've decided to stay in health privacy. Now, that may not be important for you, but it's good for me.
Well, this is sort of in the same vein, and I missed the beginning of your talk, so I'm sorry. So I've got a 20-year-old kid, he's a college student. If I ask him if he cares about privacy, he says no. On the other, or not much. On the other hand, he goes out of his way to obscure his tracks, be anonymous, use other names pseudonymously, keeps his door shut most of the time. It's obvious from his behavior that he cares about his privacy, but if you ask him about it, it doesn't come up. And I'm wondering, how do you even factor that in? How do you even begin to address that in research?
Well, I think you need to get away from asking about privacy and ask about specific applications of it, right? So are you worried about, people seeing your grades? Are you worried about things that you post being sent to your graduate school application? And are you worried about this? And I think, you got to remember when people are 20 or 21, they are not only not thinking long term, they're also invincible, they're immortal, and more spontaneous than perhaps we are. So it's a way of thinking, but what we would call privacy certainly is broad enough to include many of the things that young people do, and I think as they go through their lives, depending on lots of contingencies, they will perhaps grow to appreciate the need for privacy even more.